for many years, KRAS, as a matter of fact, I've written editorials on this. KRAS has been called the undruggable mutation. And for many years, it has been. So Ben, why was it described as undruggable, and what has changed to make it now druggable with a therapeutic agent?
Yeah, I think I just want to throw out a disclosure that I am not a card-carrying molecular biologist, but certainly have learned a great deal about the undruggability of KRAS as these new novel therapies have come into play. And I think what we know historically about KRAS is that there are specific features of the molecular structure of this protein that result in this protein that has shown a high resistance to small molecule modulation. And small molecule modulation is how we've moved the field forward for EGFR and ALK and other receptor tyrosine kinases. And so, you know, we're learning more about why this is. A few things, just getting down to some details. KRAS protein in itself, the mutated protein, has a smooth, shallow surface that makes small molecule binding very challenging, and that GDP, which you talked about, almost exclusively occupies that pocket with such a high degree of affinity, and as you mentioned, locks it into the on state, where the pedal is put to the metal, and the gas is on and is constitutively activated, and you have all this downstream signaling. So, you know, if you can't have interference with a small molecule inhibitor, coupled with the idea that GTP is exclusively locked in that pocket, you're going to have uncontrollable cell growth. And I think that this G12C mutation has lended itself to some therapeutic vulnerabilities. We know now that that altered protein, and unfortunately, other KRAS mutations may not have an altered protein that lends itself to therapeutic vulnerability, but this altered protein does have a potential pocket located near the GTP binding pocket that can be accessed by a small molecule inhibitor. And once that small molecule inhibitor binds to that altered site, it can essentially lock that protein in its GDP bound state. And so if you can get that protein to lock into GDP, it essentially renders it inactive or not constitutively active. So essentially shut down all the downstream signaling. And so that's kind of the basic overview. And David, I don't know if you've been obviously very well versed in this field. I don't know if you have anything to add to that, but that's my take on the undruggability of KRAS and how we've been able to exploit some of the therapeutic vulnerabilities given the shape or the protein pocket of the altered mutated protein overall.
Well, that's a very thoughtful explanation, Ben. I like it. Would it be fair to say then that the reason KRAS mutation has been called undruggable is both structural, that's the smooth, shallow, and biologic or functional, because also high affinity binding.
Yeah.
So that it's hard to displace it.
Yeah, I think that's a good categories here to think about in terms of the undruggability.
And for the same reason then, why haven't drugs been able to be developed for these other variants like G12V and D? Is it just because of these structural and affinity characteristics?
That's my understanding. I think that they don't have the binding pocket that has lent itself to small molecule modulation. I think that again, I'm not a card-carrying molecular biologist, but I hope that there will come a day where we do develop some drugs that can get into these spaces a little bit better than they do now and mirror some of the successes we've had with KRAS G12C.
You know, it's very interesting. I get a lot of consults for second opinions or calls from oncologists. Everybody is aware that there's something going on with KRAS.
Yeah.
But this week, I got 2 requests to see patients with KRAS mutation, both from the same oncologist. And I said, what do they have? They have KRAS. I said, which one? He said, I have no idea. You know, everybody is learning it's important, but I think the purpose of an interchange like this between you and I is to try to shed some light on why it's important.
Yeah. It's even for someone like me who's a dedicated thoracic medical oncologist, again, for patients in which we are screening them for potential trials. They've been on immunotherapy. We'll talk about potential immunotherapy utility for KRAS alterations and co-alterations that may impact on outcome. But it's forced even me to say, okay, we did the molecular testing about a year ago. We now have some studies looking at specific KRAS G12C inhibitors. Time to go back and look to see exactly what KRAS mutation they had, because it is so important to parse that out. So it's a very, very good point.